There are some centers that done some work on retinal vein occlusions as listed on Onitsha, Port Harcourt, Jos, Ekiti, and Benin. We also noted that currently there are more facilities in Nigeria now for diagnosis and care of retinal disorders, including retinal vein occlusions, and you have a lot more retinal specialists and even cardiovascular specialists to handle the disease. We decided to do a little literature review, try to list some achievable objectives, and then present a research proposal, a protocol for adoption. The objectives as listed to determine the magnitude, severity, and presence of complications once the patient presents in whatever center they present to enumerate the risk factors in our own patient, determine the current modes of management and challenges to that management noted by practitioners, and as much as possible to disseminate the results, hoping that it will lead to policy change and for the society to be able to compile an evidence-based preferred practice pattern for management of RVO in Nigeria. We are hoping that the study will be a nationwide study that will spread through all geopolitical zones, that is as many centers that are willing and where we have a committed anchor person that is consenting to the study, willing to adhere strictly to the protocol adopted, and hopefully that it will be data that will be collected over 2 years and with an initial review in the first 1 year. Of course, it's expected that we somehow will be able to get funding for the study to be realistic. I will be going through the draft protocol, and it will be good if we could note it so that we can make our comments if we are adding things to it or if there are questions. The protocol should be able to state what center and then to identify that patient such that if there are problems, the patient can still be traced back to whichever center, initials, hospital numbers, age and sex, occupation, educational status, ethnicity, contact address, including phone numbers, preferably phone number of the patient and maybe another next of kin, just in case something happens to the phone. Also, to get the presenting symptoms and duration of such symptoms, then the presence of systemic diseases and their duration, hypertension, how long the patient has been hypertensive, as listed, and others that may not be listed in the protocol. If the patient has had a previous history of vein occlusion before, if it is yes, to now go ahead and specify the laterality and the duration between when the patient had it before, how the patient cared for it, and between that and the current presentation. The patient is a known glaucoma patient. You should state the type and how long the patient had the diagnosis of glaucoma made. Sometimes patients it's now that they have the RVO that the diagnosis is made. It would also be nice to note that. To be good to note the source of medical funding. How is the patient paying for their treatments? Is it insurance or they are paying out of the pocket? And then to note the laterality of the condition, whether it is right, left, or bilateral. Even if it is bilateral, it will be noted as bilateral. Then each eye will now be dealt with singly when you do the examination. General physical examination, height, weight, BMI, BP, pulse rate, and the regularity, particularly important for patients with suspected atrial fibrillation. The visual acuity of the patient presenting best corrected either pinhole or refraction, preferably refraction, but sometimes it's the pinhole that is the best corrected that can be obtained at that point. Checking for presence or absence of relative afferent pupillary defects, iris neovascularization, and then the characterization of the type of the vein occlusion. Macular edema if present, vitreous hemorrhage, the intraocular pressure the day the patient presents, in the index eye and then the contralateral eye, because it will be necessary to compare both. If the patient has neovascular glaucoma, if there are other orbital pathologies present, if it is present, then you have to specify what. Hopefully, all patients should do OCT, but if they can, yes. If they can't, no. If yes, it would be good to measure the central macular thickness, and we'll have to do that in the index eye and still record that for the contralateral eye for comparison. The same with fluorescein angiography, the patient had it or if the patient didn't have it. Fasting blood sugar and throughout postprandial, glycated hemoglobin, and then fasting lipid profile. The genotype, full blood count, ESR, ECG, specifically checking for atrial fibrillation, and then if the patient could have a carotid Doppler, just to measure the intima thickness. Then we'll go for the treatments for patients that had macular edema with a long list of what could be done, and if it's anti-VEGF, to state which one. If no treatment was given, to give reason for why treatment was not given, and then treatment for those that have proliferation also, and attempting to get an outcome of whatever treatment was given, 6 months, 1 year, and 2 years after. These are references. Thank you.
Okay, can we have the lights on, please? So, well, one of the things we started out to do in the Retinal Society was to fill the information gaps that we have in terms of research of retinal diseases in Nigeria, and that's why we started out. At least let's start in a small way. We know we'll get better as we go on. And subsequently we can take other studies on. So we'll take questions for the first 3 presentations, and then we'll take a tea break and come back for the other session. So please, if we have any questions, especially for Professor, ask him all the difficult questions. All the tough questions you've been looking for who to ask him. Okay. Well, my questions are not for him, but I want to congratulate him on his cases. They are very tough cases. I just want to make a remark that, you see, when you see those cases being done, maybe you see them in the clinics and refer them. It's not to expect them to have excellent. The counseling you give to the patients have been very important. All of them already have fovea ischemia, macular ischemia, like you mentioned, you give out injections. Even worse. So, I always tell the patients that okay, all right, yeah, I understand. So I always tell the patients that I'm just trying to prevent them from going blind, and that the real truth, the scenario, particularly those very tough combined traction cases you see, that the real truth is that they're on their way to being blind, and there's little that can be done. And I'm just doing those surgeries as a way of hope, as a last-ditch response. You know, it's not that you're going to finish the surgery, and because the patients want to know that you do the surgery and I will see. So very invariably, many of them will come back with maybe 660 counting finger vision, and depending on how you've counseled them, they're happy. If you've counseled them, giving them such expectations that they're going to see very clearly, the patient's always asking, am I going to see? Even after you've told them everything in the theater, they're still saying, am I going to see doctor? And when they start telling me, am I going to see doctor in the theater, I tell them to wait, that we have to talk again in the clinic. So I bring them the next day, and we have to still discuss further with their relations, you know, to make sure they understand that what we're trying to do is to give our very best. It may go favorably, many cases may not go as well. Now, I have some comments so I want to congratulate you on those very tough cases. Yeah.
I think we have several kinds of patients in the clinic, and you really have to differentiate, because we don't want the angry patient because of his economic condition, because his wife is cheating on him, because he goes to dialysis three times a week, and he's projecting his anger on you. So this is the type of patient you really don't want to handle. No, and actually, I run a charity clinic. I go once or twice a month, and this was like really a dilemma for me because I've seen a patient coming. He's a street guy, very unclean. The hygiene is zero. And he did a surgery in one eye somewhere else in a government hospital, and probably he did not get his medication, he did not follow up, and you are in the dilemma of having an advanced case for the other eye, and he was projecting his anger on the doctor, by the way. And you know that you can help him, but in order to help him, he has first to help himself, right? So this was a big dilemma for me. Shall I go for the surgery? It's just charity, he would pay nothing. But would he be able to continue, the post-operative care or not? So we face challenges every day. So this is one thing. I'll tip you off with what I say to the patients that are coming and really want to go to the toilet on their own. They need ambulatory vision. They need a couple of meter, 3 meter, because of the feeling of the being handicapped is really troubling for them. I tell them this. If you chop your hand, and it's on the table, are you able to move your fingers? They will say no. So what we do is we try to fix your hand, fix the vessels, mind up the bone and everything, and we should wait for a couple of months, for 6 months, to see. You can raise a thumb, you can not move your hand at all, or you can move your whole 5 fingers. Depends on so many factors. So don't ask me from me miracles. We do the best we can in your condition. And remember, what brought you here is what you did in your past 25 years. We're healing 25 years or trying to help you in the past 25 years. Those people who would appreciate you would make a change in their life by working, probably this is an only eye, the cases I've shown you, it was the worst eye or the only eye of patients like that, by gaining ambulatory vision. I have 3, 4, 5, 60, and they walk around to their toilet. They don't depend 100% on their sons or daughter or grandsons or granddaughter, and they really appreciate the add-on we can get them into it.
So thank you very much, Doctor. Well, I'm not done with mine. If you don't mind me just finishing mine. Okay. Well, so that was a very good take home. Then the other comment I have is not for Ihab, it's for Tony. And we did a review of 1,000 vitrectomies we've done, and we found out that the commonest cause for vitrectomy surgery in those thousands, in those 1,000 series, over a period of some years, the commonest cause was rheumatogenic retinal detachment. The second commonest cause was diabetic vitrectomy. The third commonest was trauma related. And the fourth was sickle cell, ranking above vein occlusions. Because I heard you say something like vein occlusions were the second commonest cause of loss of vision. Wait, hold on, and that's what's in the literature. But like you said, the literature not looking at our own society. So you might be surprised that sickle cell may even rank higher than vein occlusions in our own society. So the common assumption we usually have that, or what is commonly seen in textbooks, that vein occlusion is second commonest cause of retinal disease, second to diabetic retinopathy, may not hold in our environment if we truly investigate it. So it's something I want to put to you to investigate, because though we've chosen vein occlusions already, okay, as one of the starters for us, we may also have to consider looking at sickle cell. Now, probably sickle cell may even be more of a problem for us than even the vein occlusions. So I think that's my comment. Then, on the issue of the methodology, I think that our aims and objectives have to be very clear. The aims and objectives of the study, if we're going to be doing such a study, and there has to be proper standardization. We have to say, is OCT involved or not? So there's still room for a lot of improvement in your methodology. We can't do a proper study without looking at issues that relate to ischemia. And if we're going to be looking at issues relating to ischemia, we have to do a fluorescein angiogram. So because if we're going to be, perhaps we should look at other studies that have been done and then see how, not just our own local studies, what prevalence and all those kind of things, but looking at the models that have done and trying to measure up, if not even surpass those standards. Like you said, funding is required. But if we're able to draw a proper protocol or even do some form of a cohort, then we can present it to Novartis or whatever and say this is a national study. We are looking for sponsorship. And who knows, we may be able to get something to do something reasonable, looking at proper sampling techniques. So I think that's my own comment to you, and it's something that we can work on. In terms of collaboration, we are doing a retinal detachment study group. So, I'll be talking more about that when I'm presenting, but it's something that I think there's a starter. As a starter, we can begin with it, but it's to do it properly. If we want to do something, we should do it properly. So those are my comments. I think Prof. So who am I handing over?
Yeah, good morning, colleagues. Once more, Professor Ihab, welcome. And we thank you for being with us again. These were a very good presentation. The chairman of the Vitreoretina group, Dr. Femi, thank you for enlightening us on the OCTA and Ihab and the diabetic vitrectomy work and Tony on your protocol for vein occlusion. You've been on it for years. Thank you. You are now presenting it to us. Let me take on Tony first. The protocol is good. Whether it is the second or not, we need to start doing something about things we see. Sickle cell may be higher depending on where you practice. It is likely to be higher in the southwest than, say, in the southeast. So that is clear. But whichever one, let us face it because it is our problem. And in your protocol, you mentioned iris neovascularization. That is okay. But I think if we are going to do this, we have to do gonioscopy on everybody. Because at times, like Paul Foster once told me in Brazil, maybe we are having this problem because of spikes of angle closure, leading to very high pressure and compressing the vessels. So we need to look into that to see whether there is any difference between the angles of the eyes that had that occlusion and the contralateral eyes that had not yet had occlusion. And also to afford us the opportunity of seeing whether those rubeosis iridis actually extended to the angle or not. The presentation by Femi and Ihab, they are good, but I will still go down to the level of prevention. These things look so good. And he once mentioned the reality that after all this struggle, some patients may come out not happy with the vision. And so we still have to go back to prevention. And we have to start. Diabetes is something that not many people know about. I do not know when last all of us, the proportion that had measured their blood sugar in the last 6 months in this room, even as we are treating them. So these are important things to consider. So we need to get our physician colleagues and GPs to start early. If whatever we want to do, we have to collaborate with them. To start early, warn our people, tell them, and not pretend that these problems are not there. At the strategic meeting for the past 2 days, we kept harping on instrument maintenance technicians. Vitrectomy is good, it's an expensive process, but with our dirty electricity, the instrument may fail in the middle of surgery. But your prevention technique is not likely to fail unless you haven't given the correct message to the people. This is where I stop for now. Thank you very much.
Thank you.
So one comment for you guys. Dr. Fimi's presentation was outstanding. Very nice overview of the OCT, and I usually just acquire more knowledge by listening to Mr. Chairman here. So thank you for that. The way we look at technology can be twofold. Whether, remember when we were kids and we used to make the additions and calculations and math and multiplication by our own brain, remember? And then comes in the calculator. So we can either be better clinicians by looking better into the macula and the details. Fimi showed a beautiful PED that we would have taken as a macular hole. But if you go through the tests that exist on the slit lamp, by the side of slit lamp, the slit beam test, the small star that exists, and the patient would see the star, we would question ourselves. The same goes for the bitter macular traction in myopia as well. So we can be better clinician while sending the patient. We would know that he at least would not be having a macular hole. He's having something that we cannot realize, a PED, local PED, or we can wash out our brain and depend on the OCT. For the choice is yours, really. I mean, the choice is really yours. What I do in the clinic is I use the 70 diopter lens to evaluate the CD ratio. And whenever the OCT comes, I am usually up to that standard. And this is an acquired exercise that you should all be meticulously doing in the clinic. Remember that we are the only clinicians that sees everything to the very minute details. We are the only clinician that would see RBCs and white blood cells and details of the things going into our body. It adds a lot on each person of you. So either you use the calculator or your brain is really up to you. This is one point. The other thing, I think Fimi just didn't go into it, the EDI, the Enhanced Depth Imaging OCT. There is a whole technology going on filming the choroid now with different levels of the choroid, and more is coming, and I think a lot more will be explained on that basis. That many of the pathologies we thought were in the RPE or in the retina might be originating from the choroid, and with the EDI, with the Enhanced Depth Imaging OCT, we would know more about the pathogenesis of many other diseases. Thank you.
Thank you very much. Dr. Okonkwo, thank you once again for your comments. And I just want to remind us that one of the reasons why we picked our view was because at the last meeting, we were actually, I think, most of the topics were focused on vein occlusion. And then we had presented a form of rudimentary multicenter study on retinitis pigmentosa. And I joined Professor Nwosu to still say that even though it seemed that our view, sickle cell retinopathy was, topped our view in your study, we can't use that to negate things yet, because your center is a...
Saying that you should do that. Listen carefully.
No. I know. Let me just finish explaining, sir.
I'm saying that it's always been said that vein occlusion ranks, and you quoted that.
Yes,
vein
sir.
occlusion ranks second to diabetic, but we don't have any evidence in our own...
Yes, that's what I want to explain. I'm saying the same thing, almost the same thing as what you're saying. Yeah, that your center is a referral center for complicated cases. But if we do this, and it's at the point of presentation, we may actually find it to be true that sickle cell retinopathy, then we can now...
That's what I'm coming from.
Yeah, that's what I was going to say before you punched it to me. Yes, and that's why we're going to do this study. We concluded also that we know that many of our centers are not in the ideal state. But with what we have, we are still better positioned to do this kind of study than depending on whatever comes from outside. Dr. Adenuga and I talked a lot about this OCT and FFA matter. And I agree totally with you that that would be the best thing to have them done. That is why we presented the issue of funding. When we talk about funding and we are reporting to the House, we are depending on the wealth of experience of everybody present. If we have good funding, we could have OCT in like 6 different centers, and patients that are recruited into the study can get it free then. But we are not going to, because of not having OCT, not be able to answer the objectives. I listed at least, we compiled it to about 4 objectives, clearly stated. Quite a number of them can be answered by good clinical examinations. So we do not want to just hinge everything until we get everything perfect. And that's why we also, I agree with you that we have to standardize it. That's why we're saying that we will need an anchor person that is committed to following strictly the protocol. When the nitty-gritty comes, then we'll be able to do that. Thank you, Professor Owusu, for reminding us to add gonioscopy to the study, and we're going to do that. Thank you.
Okay, so we thank everyone for the comments. Prof.
Sorry for coming again. We shouldn't, let me just break it here. We don't need to be at Moorfield or at Johns Hopkins before helping ourselves. If OCT is the only hindrance, we may still go ahead and then at the point of reporting, make it clear that that is our limitation. I tell you, Femi presented OCT and geography. Maybe when we come next year, it would have become obsolete among those practicing, say, in mass compound. And by then, maybe Kwame would have brought OCT here to us, and we are saying, no, it is no longer good enough to study what we want to study. Let us do what we can. Remember that excellence is always different from sophistication. Excellence, like you said, good clinical examination can give you more than 80% of what you are looking for. And then you tell yourself, yes, given our limitations, this is the much we can say. When more technology comes, we now go further. Until the 90s, everybody was saying, no diabetic retinopathy in Nigeria, very low, very low. Until whatever little we have, we encourage people to just look in. And it is obvious that 3 out of 10 people we see with diabetes have retinopathy. So I think such multi-center studies will continue. What we'll be looking for is how to refine the protocol and then look for funding. It doesn't necessarily have to be from multinationals. For those in the universities, you look into see whether you can get Senate grant or from TED fund. However small, you continue doing what you want to do. But I think the most important thing needed is the commitment of those who will do this work. If people are committed, where there is will, there is a way. Thank you very much.
Yeah, okay. Thank you very much, Prof. As with reference to the study, we're going to do all our possible best to get the highest possible quality into that study, have the best that is achievable. Because like Prof said, going forward, what we think is standard today, tomorrow will change. But within the resources we have and getting the best of a protocol analyzed and the commitment of the people, we'll see how far we can go. But this is a definitely good way to start, and we'll keep going on until we can be the best. So if there are no further comments, we'll take a short tea break. We should be back here by 11:45 so that we can take the other talks. And if you do have questions, please write them down and we can still address them after this. Thank you very much.